Welcome to the Invisible Wheelchair Podcast. I'm your host, Donald Grothoff, along with my wife, Gina. Our goal is to give voice to the hidden mind of obsessive-compulsive disorder, better known as OCD. In this podcast, we are interviewing yet another person dealing with OCD either professionally or personally. So stay with us for this impactful conversation. We would love to have your comments or to have you as a guest, or if you wish to tell your OCD or anxiety story, please visit us at invisiblewheelchair.com. So let's find out more about who we're interviewing today. I am honored today in this podcast to be able to introduce you to Dr. Jonathan Hoffman. Dr. Jonathan Hoffman, PhD, ABPP, is a licensed psychologist in the states of Florida, New York, and Utah. Dr. Hoffman is a clinical director of the Neurobehavioral Institute, NBI, which he co-founded with Dr. E. Keisha Moritz. He supervises postdoctoral residents in NBI's APPIC approved training program. Dr. Hoffman is board certified in cognitive and behavioral psychology and has served as an examiner for this board, which certifies practitioners in this specialization. He is a member of the Scientific and Clinical Advisory Board of the International OCD Foundation. He is on the faculty of the IOCDF Behavior Therapy Training Institute. Dr. Hoffman has authored and co-authored publications ranging from Understanding OCD and Addiction and the book Stuck about Asperger's and obsessive-compulsive behaviors to humorous psychology-themed articles. He recently co-authored a book chapter about using neural network models to understand psychopathology and its treatment. Now, before we get to that interview, let's hear a word about our sponsor.
Today's podcast is sponsored by Q Sciences. Don and I discovered that the supplements we were taking and giving to our children were not being absorbed properly. I was very excited when I found Q Sciences. I was impressed with the quality of the products and that they provide maximum absorption. They have a variety of products, including a Q Max product, which is a combination of 3 products, including vitamins, minerals, and a probiotic. They also have hemp oil, a vitamin B12 spray, a sleep spray, and kids products. I've really seen a difference in how these products are improving how I feel, improving my mental health, and I'm happy with the quality of these products and how they're helping our whole family. If you'd like to learn more,
simply go to qsciences.focusedhealthyfamily.com. That's the letter Q, sciences.focusedhealthyfamily.com, or visit invisiblewheelchair.com and find out more information there.
and stop throwing your money away on supplements that don't work and use a quality product like Q Sciences.
And now, on to the podcast. So, Dr. Hoffman, thank you so much for being part of the Invisible Wheelchair Podcast. It's great to have you here, and I'm looking forward to us talking.
I'm glad to be here, Donald. It's a pleasure, and I'm so glad that you're doing the work that you're doing, and I think it's awesome to just keep providing more information, more connection for people with OCD and related conditions. So, thank you.
Well, thank you, too. And as I ask all my guests, is to maybe give a little story, maybe about yourself, how you got started, or just a personal story that kind of gives them a little different taste of who Dr. Hoffman really is. Can you do that for us?
I'd be pleased to. Well, I'll tell you how I got involved with OCD, just to sharpen the focus on it a little bit. Somehow my road, in terms of my training, brought me to a variety of different positions. I've been a police psychologist, a school psychologist. I've worked in a whole bunch of different areas. Way back in let me get it right, around the mid-1980s, I was working at a hospital, a psychiatric hospital that was freestanding. Through social connections, I knew some pioneers of work in OCD. And they started admitting patients to the hospital where I was working. But since they knew me, they said, "Hey, would you like to be involved in treatment of our patients?" And from the very first person I worked with, maybe because he had a very good outcome, a serious situation, I saw the amazing difference that evidence-based treatment for OCD made, because frankly, people weren't doing that a lot of places. And to see people and to have the opportunity to work with people who had true expertise and to learn from them and work alongside them on these cases within a hospital setting was my first introduction to OCD. Not that long after that, I started working actually at the clinic that they had founded on Long Island in New York. I worked there for many years. And then about 20 years ago, I relocated to Florida. And along with my partner, Dr. Katja Moritz, we have Neurobehavioral Institute, which is our clinic, which has offices in South Florida. We do some work through Dr. Moritz, who was born in Brazil. And in Brazil, aside from our clinic work and our program, we have a residential facility for adults with complex and severe OCD called NBI Ranch, which is just a short drive away from one of our offices, also here in South Florida.
What a great story. I mean, you've been deep into the OCD for a long time, it sounds like.
Yes. Like many people, I guess, who get into this field, I guess you could say we ourselves get kind of obsessed with it and kind of compulsive about it. It's really one of the things I really love about this is you never stop learning. And I will say you learn the most from the patients that you work with, because they're the ones who are living the experience, the families we work with. Well, an interesting thing is that when I started, when I told some of my colleagues originally that I was going to be going into the specialty, again, back decades ago at this point, they were like, "Why are you doing that? It's like all the same and nobody gets better." And boy, were they wrong. And I am glad I didn't heed that advice.
Yeah,
So,
really.
but at that time, there were very few centers that really specialized in the treatment of OCD. I remember this was before really effective OCD medications. The exposure and response prevention was known, but not well popularized. It's certainly not being done at the level of understanding and effectiveness that it's done today. But that could not have been more wrongheaded. And plus, at that time, I don't think people realized fully just the prevalence of OCD and all the conditions that intermingle with OCD. Glad for that I didn't heed that advice. So again, that's been kind of my path.
Well, yeah, and I've seen that. I mean, I have two kids that dealing and one in severe OCD, and so I've learned a lot from them myself, and so I understand that. And I always say is kind of the nicest part about it is that it is manageable. It's not, I don't know if you agree, but I don't think it's not really curable, but it's manageable. And that's the nice part about it.
It's very hard when we speak about curing something. I mean, I guess you could cure certain medical conditions by just removing them so they don't exist anymore. But OCD, and I think one of the fascinating things about it is it doesn't exist in this purely tangible way. Sure, there's neurobiology and there's all sorts of medical aspects to it, but they're not standalone or fully explain OCD, because we have, and again, this is one of the things that really fascinates me, is that it interacts with behavior, it interacts with families, it interacts with society, it even interacts with philosophy. So OCD, like, what would you really be curing? Because you can't put your finger on it as a single tangible entity. And that kind of idea really informs the treatment of OCD where I work. And it's OCD is far more than its symptoms. For some people, it's a way of life. And one of the nice things about it is you can't kind of think your way out of OCD per se, but in many ways you can behave your way at least to a great improvement. It's so interesting that you could have the most severe OCD symptoms, but yet you could through some medicines, primarily behavior therapy, you could learn to increase your capacity to deal with uncertainty, deal with emotional distress. You can learn how to inhibit compulsions in a way that makes OCD much, much more manageable. So I guess that was a long way of saying I completely agree with you. Not curable, but highly manageable for many people.
Well, and it actually steps me a little more. I was going to talk about this a little later in the interview, but one of the things I caught on one of another interview you did, you talked about about taking away the idea of making it human or making it a bully. You talked about it's really enhancing or helping people. And I kind of wanted to touch on that because about a couple months ago, I caught I think it was another podcast, and the lady on the podcast was talking about she makes hers an innocent child,
Mhm.
and a completely different way of thinking about it. I mean, we've always gone down the bully road. That's a bully, fight the bully, all of that kind of stuff. And that thought that she put out there was like, oh, that's really interesting. I never thought about that. And then I heard you say about it being, the how did you put it? Let's see. I think I put it's trying to help you is what I think you said. So I'd like to touch on that a little bit more because I find that really fascinating.
Well, I do too, and I don't know the answer to this because this is kind of the made-up part of dealing with this, how we conceptualize OCD as a part, as aside from the more sciencey parts of it. What is the neurobiological aspects? What is the learning theory, the behavioral approaches, and the mechanisms of actions of all of those things? But I think it is important to have a way for people who have OCD to think of it. And people have tried all different ways. People have originally conceptualized it as a bully, or a parasite, something trying to take you over, or a mischievous imp, or which was the title of one famous book about OCD, or all these ways of thinking about it that actually puts people in competition with the OCD or standing up to it. And that's one, that can be very helpful in some ways. And you can think about it in all different ways. But I guess my way, of thinking about it, and not just mine, but a lot of people, ways of thinking about it is that by fighting it, you actually give it more reality or more credibility. And we now go for more about experiential acceptance, that you want to just accept whatever the thoughts are, whatever the impulses are, and refrain from behaviors that would, not be helpful given those thoughts, refrain from compulsions, in other words, and at the same time, find a way to live your life despite what's going on inside you. In a way, almost like treat your inner experience as if which is true, it's not entirely synonymous with who you are as a person, and take some distance, or as people say, diffuse from that experience so that you can deal with it more effectively. Almost like it's happening, but it's not you. It's just kind of these things that are happening. But what is actually happening, I guess, gets to the heart of the matter here, is that our brains, our physiology, it wants to survive, but sometimes it gets kind of some cockamamie ideas about what survival actually entails. And OCD, is like a sense of danger, which is not accurate, and coming up with ways to protect from danger, which is largely irrational or totally irrational. Even if some person sees a kernel of truth in it and makes these connections, but it's all meant to make you feel better, make you survive. But unfortunately, it's actually miscalculating, and it does just the opposite. So if you're feeling in danger, like the world's like uncertain, and you're going to try to line up all your ducks in a row, actually a sensitivity to uncertainty and need to control it is only going to get higher. If you want to feel really safe and you won't take any risks in life, you're impeding your life, and you get more unsafe. So I just think of all of this as just kind of a system that's kind of misguided. For some people, we discuss it as, it's like an overprotective person in your life. Could be a parent, could be anything like that. That's really means well for you, except they're giving you really, really bad advice. So that is kind of the way kind of I would think about it more these days. But I think that's consistent with kind of overall trends in the conceptualization of OCD and what might be the most effective kinds of treatment.
Kind of the bad helicopter mom. No.
OCD, exactly. It's a really bad helicopter parent, trying to tell you better watch out for this, or if you do this, your life will work out. But it's terrible advice. So I think part of the journey in OCD is this self-perception independence from what's going on inside you, or again, experiential tolerance, but also kind of like, yeah, thanks very much, but I think I'll do it a different way,
That's a neat way to look at it. It really is, and I also like the fact I noticed you mentioned there. You said people are whole people,
Mhm.
and I think I work with naturopathic doctors in what I do and the work I do, and they look at the whole person when they're healing. And I thought that was really, again, another fascinating point with you is that you look at the whole person instead of just this one piece, I guess. And maybe you could expand a little bit on that.
Sure. Well, when someone has OCD symptoms, it's just part of who they are, of course. And they can lose themselves to the OCD, or they can reassert their ability, as I said, to function even though they're having OCD and kind of live their lives. But what kind of life do they want to live? If you're restricting your life because of OCD, well, that's not living your life to the fullest. If sometimes OCD, of course, intermingles with impulsive conditions. So if you're doing very risky behaviors that are going to put you in harm's way, that's not very helpful either. So I think by looking at the whole person, their family system, their learning skills, again, the comorbidities that surround and interact with OCD, sometimes primary, sometimes secondary, sometimes hard to tell, but they're more the rule than the exception. You know, a high proportion of people with OCD have at least one comorbidity, often many more. And just understanding what people, not only the clinical aspects of this, but how the given person has dealt with challenges in their life. Do they feel stigmatized, or do they feel like, hey, I'm going to be a spokesperson for this? You know, so many factors go into OCD treatment. And again, that's one of the fascinating elements of it. And also the challenges of the dual challenge, I think, of treating OCD is to utilize evidence-based treatment very fully, at the same time, personalize it so the whole person is being considered. In other words, not just making it kind of a formula like everybody's with OCD is going to respond to something in a certain way, but realizing how a given individual, what they're bringing to the table or not bringing to the table in terms of their ability to manage their OCD symptoms. So that is a whole person approach.
That segues beautifully into the idea of the and I'm not as good as saying this, comorbidity. Is that how you say it?
Comorbidities, or kind
Comor-
of synonymous with co-occurring conditions or associated conditions, but all these different diagnosed conditions or just kind of issues that tend to, again, intermingle. I think that's a good word, or intersect with OCD. And the thing is that OCD can intersect with just about anything, or become part of anything, or become a consequence of different ways of handling different other conditions. And, so we look at things about what came first in a person's history. Did the OCD come before the depression before OCD? That's again, different ways of understanding. Is the person depressed because they have OCD, understandably? In other words, is it a primary condition or a secondary condition or even a tertiary condition? But it becomes very like detective work in unraveling all of these different elements of OCD. But that helps us understand, produce, as effective individualized treatment plans as we can. But some of the comorbidities that intermingle with OCD are attention deficit hyperactivity disorder, eating disorders, autism. I think pretty much anything you can think of, other kinds of anxiety disorders. And then we have the OCD related conditions like body dysmorphic disorder, which is, over concern with an obsession about, minor or not even to other people non-existent aspects of appearance, skin picking, hoarding intersects with this, hair pulling, trichotillomania. And then just, the list could go on and on about these kinds of the conditions that coexist or are comorbid with OCD.
Would you say that this is just kind of coming to me now, but is there a spectrum with OCD? Is there a lower end and an upper end kind of thing with OCD?
Sure. I mean, OCD it's extremely variable. I mean, some of the core elements are the same, but someone could have OCD which is relatively mild, or OCD which is completely destroying their life and debilitating them. You could have OCD that the symptoms stay pretty much the same across years, and OCD that seems to be like whack-a-mole. You deal with one and then another one comes up. It's a very, I guess, a kind of a fancy word would be protean, I guess. I think that's the word, that it's just kind of really changeable and dynamic, and it's always varying. So in OCD, when we conceptualize it, we can think of like the overall climate of the OCD. Then we can think, what's the daily weather in this person's OCD? How much the symptoms wax and wane, and according to it, in a week, a day, a month. And all of these things are just another one of the very challenging but fascinating aspects of what we call OCD.
As we talked about the parent, the helicopter parent, it almost is like well, if you're not going to do it this way, then okay, how about this way? And
Mhm.
let's try it this way. I've got to keep you safe, so let's try it. So it's constantly
Right,
morphing and
and then
changing.
quite literally, parents often get engaged in with a child, even an adult child, where now they're not only helicoptering their kids, they're helicoptering OCD, and they think they're helping their kid, but actually they're helping OCD grow by buffering their relative against the effects of OCD, by over accommodating symptoms. But again, it really is that classic: the road to ruin is paved with good intentions. We don't assume bad intentions if a parent is seemingly over accommodating their kid. They're doing what makes sense to them, and it's out of love. It's just, sometimes we say to people that this is a condition where, like, common sense, it doesn't always help you. It makes sense to help someone. It makes sense to help yourself feel less pain through a compulsion, but it actually will bring you more pain.
Yeah.
It makes sense to help a child, not trigger their OCD and protect them, but it actually makes the OCD just trigger more easily over time. So people are really, I really kind of call it like it's a traps. There's traps within traps within traps within OCD, and really that's kind of how it progresses. It progresses through kindness, through or to yourself by taking away some mental pain, or by physiological pain through a ritual or an avoidance, or for a parent trying to make sure that everything is perfect for the child, so that they feel better and they're happier and they don't have to spend their day doing rituals. But it's just a trap. So a lot of OCD treatment is kind of educating people about these traps. Sometimes they're fully aware of them. And I just wrote an article that's about to come out that they're in this trap, but they become accomplices. And sometimes they're fully aware accomplices, and sometimes they do it because they just don't understand what's happening to them.
Or it's late at night, and I've been down this road myself. You're tired, you're late, you're exhausted, and you give in because you just want to get to bed, or you just want to get past it.
OCD does have some advantages. It doesn't get tired. It's always ready. And yet everyone who has to deal with OCD, we have our human limitations. So
Yeah.
that's one of the things to really be, forgiving of ourselves about, but at the same time be cognizant of. And if we know late at night is the issue, to try to like hone in on, to understand our vulnerabilities late at night, either as a caregiver or as the person with experiencing OCD.
I'm hearing in this, and I wanted to ask you, you're familiar with the ACT, the
Sure.
acceptance commitment. Is that something you fall in line with too yourself?
Yes, I think acceptance and commitment therapy, also known as ACT, actually provides a really great philosophical and conceptual framework. And really, I was earlier in some of my comments, I was using some ACT ideas about experiential
Hmm.
tolerance, about living life, and I think the whole idea that with ACT, I think it's really helped provide a great conceptual framework for treating OCD. That the important thing is not necessarily what you're experiencing at a given moment in terms of thoughts, in terms of whatever's going on from an OCD perspective, but how you're going to get your actual behaviors in line with or congruent with your values and goals. And that really becomes the overarching idea that we place OCD treatment into.
The last thing I had, and I heard you mention foundational condition, that you called OCD a foundational condition.
Mhm.
And I thought it was really, really interesting and on spot in a way. And I think we've kind of covered in what we've talked about, but tell me a little bit more about the foundational condition. It
Well,
sounds
well,
like,
yeah, OCD can be, as I said, it can appear in many forms and interrelate, and it's willing to mingle with just about anybody. OCD is very friendly towards other things,
loves to
and it
party with
gloms onto.
anybody.
It'll party with any. That's a great way to put it. It'll party with any condition you could think of, or a life issue. But I think there is a fundamental aspect to OCD, aside from all of that, that actually is the basis of many conditions, and those would include that difficulty experiencing mental distress or distress from sensory issues, not being able to manage uncertainty, thinking there's an exact right or wrong way to do things, thinking that that there's some sort of, not really understanding causality is a better way to put it, thinking there's some connection between a cause and effect that just does not exist. There is a whole bunch of foundational ideas that you learn in treating OCD and dealing with OCD that are very applicable to many conditions. And within many other conditions, you can find OCD. Some people are surprised that there is a lot of perfectionism amongst people with ADHD. Mm-hmm. They may be disorganized, but the thing they want to be organized about, they'll be super organized and not like a difference in it. So sometimes it can be kind of confusing. But I think that one of the things that we've really come to understand about OCD is that that's a very pervasive condition, that not only is it a group of symptoms, but it's almost a way of living for people until they start to change it. And it kind of changes their ideas about what's important in life, what's not important in life. And it actually obscures that. You know, one of the things we know about OCD is that it reduces control over behavior, because you're almost like becoming automatic or robotic or just so fearful you have to kind of be complicit with it, or it changes changes kind of hierarchy. In other words, getting something straight in a very particular way might be as important as, you know, your studies or what you want to do with your career, that it just flattens out hierarchy. And again, in treatment, we try to alleviate that, have people really understand, be able to more differentiate, well, what's important, what's not, what's consistent with my overall values, what's not, what distress am I willing to tolerate in order to have a better life. So it is a fundamental issue in many conditions, and it has many fundamental issues within itself.
You know, I have fundamental issues with it by itself.
Mm-hmm. Right. Sure.
I guess what I would ask is, what would like a bit of advice that you might want to give out to somebody that's just maybe starting to realize they're getting into the idea that they got OCD and that this is starting to have some effect in their life? Any advice
I would give the same advice I would give to anybody about health in general. Wherever you are, start taking better care of yourself. Like if you've never exercised, it's never the wrong day to start exercising or eating right or stopping smoking or something that's unhealthy for you. You don't have to wait to start. Of course, the earlier intervention you get, the better. But if you're an individual, even individuals who've been really wrestling or just have been very impacted by OCD for many years, it's all about what you do today. And it's all about taking one step. You know, every time you take a step that's contrary to OCD or the opposite of OCD, you're actually building your possibility of taking more steps the next day. Every day you postpone it, you're reducing the possibility, and you're actually just making it harder. That's one of the really awful things about this, is that through the more you avoid, the more you don't challenge yourself, the more you don't face your fears, although it's quite understandable, because who would want to do that? The worse it gets, and the harder it's going to be for you to do it at a later time. So I would just say, to summarize that line of thought, that there's no time like now to start dealing with it.
One last thing I wanted to do for you, Dr. Hoffman, is give my audience an idea of how they might best find out more about what you do and find you.
Terrific, and thank you. So our websites are www.nbiweston, WESTON.com, and www.nbiranch.com. And you can write to our office at info@nbiweston.com through email, or just call us at 954-217-1757.
Well, Dr. Hoffman, this has been, I'm sure you could talk about it all day, and I could too. I really am so appreciative of you being on here, and what you've talked about has just been fascinating to me, and I'm really thankful for you being here on the podcast.
Well, thank you so much for having me. I very much appreciate it.
This concludes this podcast. We hope you enjoyed it. Remember that we love comments. We also would love for you to be our guest or to tell your story. simply go to invisiblewheelchair.com. Gina and I want you to know that there is hope for those who suffer with OCD and that it is manageable. And we are here to help you and your family. To find out more about our practice and what we can do for you, go to focusedhealthyfamily.com. Opinions and ideas expressed here are not necessarily those of Focused Healthy Family, Family OCD, Invisible Wheelchair Podcast, or the Grothoffs. Thank you for listening. Keep tapping and focusing forward in your journey.